Ma has already set a very nice background for my talk. She has introduced the concept of novel agents and also showed you the data based on which this drug has come to the market. Over the next 20 minutes, I will specifically concentrate on some of the data using combinations of these novel agents. And the specific combinations I will go over are these four of them: ibrutinib or venetoclax with rituximab, venetoclax with the newer monoclonal antibody obinutuzumab, and finally venetoclax with ibrutinib. And as you can see, this is not an all-inclusive list. For example, idelalisib is not there. It's an FDA-approved drug, but since we already had an extensive session for PI3 kinase inhibitors in the morning, I thought I will focus on these. As you just heard from Dr. Ma, that ibrutinib as a single agent is very active in CLL, as well as earlier we heard in follicular lymphoma. On the other hand, rituximab is a drug that has improved the activity in combination with many agents. Therefore, it's reasonable to try and see if rituximab makes a difference when combined with ibrutinib. What's the data? Well, this is a study that was presented in ASH 2017, looking at ibrutinib plus rituximab compared to ibrutinib alone in patients with CLL. As you can see here, this is a randomized study. It included relapsed refractory patients as well as treatment-naive patients with high-risk cytogenetics. Patients were randomized to ibrutinib or ibrutinib plus rituximab. Standard doses were given. Rituximab was given in the first cycle 4 doses and subsequently 1 dose with each cycle up to cycle 6. What this shows is that the ALC, the absolute lymphocyte count, came down fairly quickly compared to ibrutinib alone when it was combined with rituximab. There was a significant difference, as you can see, and the p-values indicate. As if you look at the months, almost 9 months versus 3 months. That's one observation. The other observation is, if you look at the treatment-naive patients, this green indicates complete remission. So they had 20% complete remission with ibrutinib. When combined with rituximab, it was 50%. So there was improvement in CR rates. But you can see the overall response rates were very similar. If you look at the progression-free survival or overall survival, essentially there was no difference between the two groups. So rituximab does not appear to add much to the efficacy in terms of outcome, whether it is PFS or OS. And that's what we have seen in studies with this combination in other diseases also, except probably you heard from Dr. Treon this morning. There may be subsets of B lymphoproliferative disorders where this combination may be useful. Like I think you heard about MYD88 and CXCR4 positive, mutation positive patients. They may benefit from the combination rather than ibrutinib alone. So there may be some subsets where it could be useful, but at least at this point doesn't seem to be useful to use it in all of them. That's why the FDA label is as a single agent. How about venetoclax with ibrutinib? Venetoclax and rituximab. So this is the preliminary data. As you know, venetoclax as a single agent itself is very active. And when combined with rituximab also, it is active. This is one of the very early studies. Dr. Roberts published in New England Journal of Medicine. Subsequently, Dr. Seymour also presented it. So it also shows that compared to venetoclax alone, the combination increases the CR rates from 20 to 50%. Again, this is not a head-to-head comparison. These are two different studies. It also shows that patients who were able to achieve complete remission were able to have longer remission compared to patients who were not able to achieve complete remission compared to patients who had partial remission. So that clearly indicates that deeper remissions may mean longer duration of remission in these patients. The study also gave us some ideas about what are the factors that may predict complete remission rate or relapse rate in these patients. If you look at what are highlighted here, the addition of rituximab or lymph node size bulky disease or cytogenetic abnormalities like 11q or 17p, as well as the dose of venetoclax, they were all important factors as I summarized here. So, what did we learn from the combination of venetoclax and rituximab? Well, in patients with relapsed refractory CLL, venetoclax is very active, whether alone or in combination. The response rates are 79 to 86%. It also indicates that the responses are durable. And multivariate analysis, which I just showed you between two studies, indicates that combination of rituximab, bulky disease, the cytogenetic abnormalities listed here, the dose of the venetoclax, these were important response modifiers for CR as well as risk of relapse. So combination with rituximab significantly improves the outcomes, CR rates as well as duration. With alone, after adjustment of the other factors, so that alone is a significant factor in terms of deciding the CR and durability. Now that we know that this is tolerated very well, and the combination leads to better CRs and better duration in patients who had CR, how does it compare to what is considered standard, bendamustine and rituximab? This is the Murano study, where patients with relapsed refractory CLL were randomized to receive either venetoclax standard doses after the 5-week ramp-up, along with rituximab, again standard doses as used in FCR 375, subsequent cycles 500 per meter square. This was compared to bendamustine and rituximab, again standard doses. And the primary endpoint was investigator-assessed primary progression-free survival. There were also several secondary endpoints that included bone marrow as well as peripheral blood MRD. The outcome was clearly superior in patients who received the combination of venetoclax and rituximab compared to patients who received bendamustine and rituximab. And the primary endpoint was reached, which is the independent committee observation assessment of the PFS. You can see that the 2-year PFS was like 85% in the venetoclax combination compared to 36% in the BR, clearly superior combination. In the same study, they also looked at the MRD status. This was presented in the ASCO meeting earlier this month in Chicago by Peter Hillman. So if you look at the schema, what they did was the bone marrow MRD was looked at before treatment as well as at the end of treatment. And they did peripheral blood MRD checking before treatment, at 4 cycles, end of treatment, and subsequently, as you can see, it was done every 3 months. And the study actually continues at this point every 6 months afterwards, after 3 years, until 5 years. So we have the preliminary data to see, number one, whether the bone marrow PCR correlates with peripheral blood PCR, which is an important question. And subsequently, how deep are these, and is there any indication that deeper remissions may correlate with longer duration of remission? The first point is that if you look at the peripheral blood MRD and bone marrow MRD, there is correlation in both the venetoclax and the bendamustine arms. It is correlating very well. And this data is important. Those of us who were involved in starting TKI in chronic myeloid leukemia treatment, remember in the beginning, we used to do bone marrows to assess the BCR, ABL, PCR status, whereas subsequently there is very nice data like this showing that peripheral blood, BCR, ABL, and bone marrow correlates very well. That's why we use now peripheral blood PCR and CML. So like that, this is an indication that peripheral blood MRD status may reflect bone marrow in CLL also with novel agents. And it correlates very well in such a way and is confirmed with the bone marrow evaluation, so that we can say that at this point, based on this data, peripheral blood MRD can be used as a surrogate for bone marrow MRD. And this was true across the different subgroups, whether they had 17p deletion or not, whether they had the IGVH mutation or not. And so different subgroups, again, the MRD response was maintained. There was no subgroup where it was thought to be inferior. Not only that, the patients who achieved MRD negativity or absence, as it was mentioned earlier, the green, they were able to maintain the MRD status negativity for some time, and the durability is very clear, even in patients in whom it proceeded to intermediate positive. But very rarely you have a high positivity, probably one patient. So, having this, obviously, the question is then, if venetoclax and rituximab is beneficial, is there a role of using the newer monoclonal antibody, second generation obinutuzumab? There is data to indicate that there is benefit. For example, this data again was presented in the ASH meeting, and it was specifically showing at the or looking at the MRD negativity in the combination of venetoclax and obinutuzumab. And they had two schedules there. In this one, for example, schedule A, they had venetoclax first, followed by obinutuzumab. In schedule B, it was obinutuzumab first, followed by venetoclax. This is obviously a small study. The numbers are very small, but the point is, across the different cytogenetic abnormalities, the combination was able to maintain the response. Also, the response was quite deep. As you can see here, the MRD negativity was obtained in majority of patients, whether they are in CR or PR. This also brings a question that we are faced with now in CLL. Even in patients with PR, you have high degree of MRD negativity. And these patients, even though we can't find any disease in peripheral blood or bone marrow, they become labeled because of a small lymph node, for example, 1.6 centimeter lymph node, that puts them into a PR status. And that obviously needs some thought about changing the way we assess these responses. And these responses were also very well maintained, as you can see here. And finally, the combination of ibrutinib and venetoclax. Obviously, these agents are very active individually, and they are also active when you combine with rituximab separately. But how about combining it? Clearly, they are acting with totally different mechanisms, and so far doesn't look like there may be overlapping toxicity based on preliminary studies. So this is the data that was presented again at the ASCO meeting earlier this week. Dr. Veda from MD Anderson presented the data study, the results of the Captivate study, which looked at the results of ibrutinib in combination with venetoclax, and these are untreated patients. So as you can see here, the list of patients, CLL or SLL untreated, and they all had indication for treatment according to standard guidelines. There was a ibrutinib lead-in period. The first 3 months, they only received ibrutinib, and that is important. And following that, venetoclax was added, and they received total 12 cycles of venetoclax. So a total of 15 months of treatment data was shown in this study. And patients who had MRD negativity, they were randomized 1:1 to placebo plus ibrutinib to see if you can drop one of the drugs and still maintain the remission. And patients who still were positive were randomized to the combination versus ibrutinib alone. And again, this was the schema, 3 months or 3 cycles of ibrutinib alone, and then subsequently the patient received for 12 months the combination. This is to show that there were patients with high-risk cytogenetics as well as unmutated IGVH, a fair number of them. And if you look at the results of TLS, the tumor lysis syndrome, that was one of the points that was brought out in this study, that the risk of tumor lysis, as you can see after the first 3 months of ibrutinib lead-in, came down from 24% of high-risk tumor lysis to 3%. Also, maybe that is related to this, that is, if you look at the bulky disease, came down from 29% to 6%. So there was a reduction in the bulky disease, and when they were exposed to venetoclax, the TLS was significantly lower also. If you look at the adverse events of the combination, diarrhea was present in single agent, but it was more with the combination. As you can see here, there was even grade 3. And also the other one that was prominent was neutropenia. Neutropenia was much more in the combination. Otherwise, the side effects seem to be fairly similar even after introduction of venetoclax along with ibrutinib. This was just to point out that adverse events leading to discontinuation was very minimal, about 2 to 5%, and dose reduction was also up to 16% of patients, 12% in ibrutinib, and 5% with venetoclax. So, if you look at the MRD negativity, this is the peripheral blood and this is the bone marrow. So, baseline after cycle 9, which means 6 months of combination, 12 months of combination, and this is 12 months of combination. This is first 3 months. So baseline 3 months, and subsequently this is what it shows. The total 1 year, 93% in the peripheral blood was MRD negative. And in the bone marrow, the same specimen at the cycle 15, it was 86%. So this was confirmed. This is what they call as the so-called confirmed undetectable MRD. That means it's a peripheral blood that was confirmed in the bone marrow. So I think the final point here is 86% of patients who received 12 cycles had confirmed bone marrow MRD negativity. This goes back to the point I mentioned. Even though the overall response was 100%, with complete remissions was only in 36, and the others were PR and nodular PR. And this was primarily explained by the lymph node size being 1.6 to 2.5 centimeter, which makes them PR and not CR. This is the waterfall plot indicating that if you look at the target lesion reduction, clearly majority of them had significant reduction. Similarly, enlarged spleen, majority had significant reduction with the combination. So what have we learned from the combination of venetoclax and ibrutinib? It's clear that the combination gives us very high response rates. MRD negative in peripheral blood, 77%, which is confirmed in the bone marrow. MRD negative in the bone marrow, 86% after 12 cycles. Tumor debulking and reduction in tumor lysis syndrome risk in after 3 cycles, that appears to have an advantage. The priming with ibrutinib might have an advantage. This again goes back to what was discussed earlier today, like HDAC inhibitor may reduce the side effect of the combining drug. So I think combination with novel agents may not only be enhancing the response rate, but also may mitigate or reduce the side effect of the combining drug. There was no hospitalization in 77% of the 77% who would have otherwise needed hospitalization based on the accepted TLS criteria, high-risk criteria before starting venetoclax. And the combination did not yield any new AEs. I pointed out the ones which were more the diarrhea and neutropenia related complications. And clearly, the fact that patients were able to achieve significantly high MRD negativity indicates that this could be a background for combination trials aimed at looking at fixed duration trials. Obviously, that is one of the big concerns when we talk about these very expensive agents being combined and telling the patient it's going to be indefinite. And I think that is realistic to hope for that. I'm coming back again to the CML scenario where about 2 decades back when we start imatinib, we typically tell the patient you'll be taking it forever. for your life. Whereas now, FDA even approved it. Yes, you can stop it if you have take TKI for a period of time and you have achieved an MRD negativity or MRD reduction to a particular level. So the trial, as we all know, this new trial, the NCT trial, which is actually in the clinical trials go a website, is specifically looking at that. So the take-home points of my talk is one, novel agents are very effective in CLL. Combinations are leading to higher responses and duration of response, and combinations do not appear to give any new signals in terms of adverse events. And finally, achievement of high MRD negativity indicates the possibility that we may be able to discontinue treatment after a defined period of treatment and still maintain the response. Thank you for your attention.